I got a little delay, so I'm a little delayed here. Today what I'm going to discuss is about first trimester fetal echocardiography. If you know the fetal echocardiography, then you are happy. But if you do not know fetal echocardiography and somebody asks you to do fetal echocardiography, this is your situation. Right. We do not want to end up in this situation because first trimester fetal echocardiography is absolutely necessary now. Before 10 years, it was a beginning. Now it's absolutely necessary to identify the first trimester fetal cardiac malformations. And the moment you start doing fetal echocardiography, you will learn it very fast, much faster than you expected. And because once you have seen this echocardiography today, then your expectations are going to be high. Then you will get frustrated when you start doing scan. But eventually, you have a continuous process of learning. Then eventually you reach to your plateau. And I do not want your condition if somebody asks you to perform your fetal echocardiography during the first trimester. There are loads of indications when you should do it. But if you want to learn 3 indications, first indication, any nuchal translucency more than 90 percentile, first thing is fetal echocardiography. Any tricuspid regurgitation, it's a first trimester new fetal echocardiography. And any ductus venosus more than 1.2 pi or a reversal in A wave, that needs fetal echocardiography. Apart from all many medical conditions where you need fetal echocardiography, including the twin, hydrops or everything. See, the problem is the fetus. This is the fetus of 12 weeks. And if you really see, the fetus is max, this is the total length is 7 centimeter. And out of that, if I open the fetal heart, the length of the fetal heart is hardly 10 to 12 millimeter. So it's a small organ. And because it's a small organ, we try to identify the small organ. And inside that 12 millimeter organ, we try to identify 4 quadrants. Right atrium, left atrium, right ventricle, left ventricle. You try to identify the arch. You try to identify pulmonary artery. So you are dealing with a small organ. It's about the small organ. I'm happy. Only thing is what I need is a better quality machine and better instruments. 12 millimeter size of any defect, you know that you can see easily on ultrasound. 12 millimeter, you identify the follicle. That is 10 millimeter, 12 millimeter. You identify the same way heart. You need to identify. For that, what you need is a better ultrasound technique, better ultrasound instrument, and high resolution probe. That's it. You need only, because fortunately, the fetal heart never changes its structure. So right at 8 week also it has got 4 chambers, 1 pulmonary artery, 1 aorta. At 32 week also it has got the same. At the 40 week it has got the same anatomy. So you are trying to reach a smaller anatomy with a better quality machine and better high resolution probe. That's what is required, because at 12 week the fetal heart is going to be chickpea size. That's what is going to be important. Unless like a fetal brain. Brain changes. Brain change at 12 week, brain change at 14 week, brain changes at 18 week, brain changes at 30 weeks. Here heart remains same. That's the advantage for the fetal heart. So you should be evaluating like that. And to do that, you have many options with you, and you can choose. Many probes are available, many superb quality instruments which are available, ultrasound technique, and that's how you should be evaluating those fetal heart very easily. Now, 2013 guideline for doing fetal echocardiography, fetal anomaly scan in the first trimester. There is no word about heart. Only thing that 4 chamber symmetrical chamber is supposed to be seen. That's it. There was nothing like you add on doing an echocardiography. But 2023, there is a complete shift of paradigm. They say now you should look for a 4 chamber. You should look for the stomach. 4 and a 3 vessel trachea view. At least you should see, with the help of color, HD flow or a slow flow with a new technique. You should identify 4 chamber and 3 vessel trachea view, so that you can still deal with more than 70% of the cardiac defect. Even if you look 3 sections, abdominal circumference, looking at a 4 chamber view, and looking at a 3 vessel outflow tract. If you see only these 3 images, still you will be able to identify 70% of the cardiac defects which are not compatible with life, and that's what the aim of doing the fetal heart echocardiography is. The simple thing, that early cardiac evaluation, you know that at 10 week, still you can see the 4 chamber, but at a 13 week, you should be able to see 4 chamber outflow tract, both arches, both vena cava, also the pulmonary veins. So it's all about visibility, and visibility is definitely far more superior. If you find these normal nuchal translucency, normal nasal bone, I'm happy that mostly the fetal heart is probably going to be normal, but when you see the nuchal is going to be high or nasal bone is going to be abnormal, please always think about one possible aneuploidy, and that means you should be looking at a fetal heart. So for me, the moment I try to look at the fetal heart, it has to start with the situs, axis, position, 4 chamber view, crossing of the major vessels, 3 vessel outflow tract, venous system, and use of your volume imaging, and that will give you unbelievable kind of images. Simple thing, fetal left and right side, that has to be decided. We use doll drawn on a left end. I think we will demonstrate how to identify the fetal left side. It is not synonymous that stomach is on left side and apex of the heart should be on left hand side, on the same side. It's not like that. It has to be, you have to identify fetal left and fetal right side first. Then on left side, you should be identifying, okay, stomach is on left side, okay, the apex of the heart is also on left side, and point of the tracheal V formation, that point also should be on the left hand side. These three things should be on the left hand side. The moment you have done this, you have ruled out more than 60 to 70% of the cardiac defect, and that's what my aim is. Another way is just clockwise and anti-clockwise system. If you find spine, stomach, and the portal vein, if you find it is clockwise, it is going to be in cephalic, it is situs, and it is anti-clockwise in case of the bridge. That's what you can identify. Of course, the situs arrangement, that you know, that situs arrangement, that the stomach and the apex of the heart should be on the same side, and that's what you can always think, like this is the apex, this is the stomach, both are on the same side, and you say that the situs is going to be normal. Like this is a second trimester heart. You know that there are 12 points to be seen: 2 situs, axis, size, 2 ventricles, 2 atria, interventricular septum, crux, 2 AV valve, 2 veins in pulmonary artery in the left. The rhythm should be normal, but no pericardial fluid, and area behind the heart should have only aorta, no other vessels. The same thing is applied in the first trimester, but the problem is you don't see only grayscale or only color. You see adding HD flow, color, or a slow flow side by side. So one side you should have a grayscale imaging, one side you should have a color or HD flow, and you identify, you should be looking at the same thing. The stomach should be seen, you see the abdominal vein, you should see the apex of the heart, 4 chambers which are fine. You can see the pulmonary veins getting into the left atria. You just go on doing interventricular septum. This is LVOT which is coming out, going towards the right shoulder. You see the pulmonary artery bifurcation where it bifurcates into 1 and 2. Then you still go up, you 3 vessel view. You still go up, you find 3 vessel trachea view. You will see everything. This is exactly what I want you to understand, that there is nothing specialized system in this, but only thing you need to have high resolution. One simple thing, looking at a cardiac axis, draw a simple line from the spine to the sternum and draw one line right through interventricular septum. It has to be similar like second trimester, 45 degree plus or minus 10. This is the best clue to identify outflow tract malformation. Any axis deviation on the left side or a right side, you are talking about cardiac defect. That is one angle. There is one more angle which is going to be there. I'll just show you again in the same clip. Let me freeze it. And this is exactly the one line here, one line here. You will see this line, and that's what your cardiac axis, which is going to be normal. And second point, there are 2 angles. One angle coming at a 3 vessel trachea view. That is what we call as a V sign angle. Draw a line outside the aorta, draw a line outside the pulmonary artery, and this is exactly what is required. And if you draw outside and you draw inside, it is 35 degree plus or minus 10. These are the 2 simple rules. If you follow, then I can tell you, you will be able to identify more than half of the outflow tract malformation. Just simple 2 things, because you have seen and measured the angle, and which is going to be fine. And because all outflow tract malformation will have quite a few abnormalities where your detection, if you have got a nuchal abnormal with this V sign angle abnormal and cardiac axis abnormal, you will be able to identify more than 93% of the cardiac defect. So that's what the value of these two angles. Simple things. I don't want to take you to all details. Look for the AV valves, look for this and that. Simple things which you can start doing it tomorrow morning whenever you go to the clinic. You should be able to practice, and that's what my aim is, to make you understand. So again, cardiac axis which is going to be there. Same rule. Cardiac position, 2/3 should be on the left hand side. If you draw a line, 1/3 should be heart on the right hand side. And the cardiac size, 1/3 it should occupy 1/3 of the fetal thorax. This is exactly what these rules are followed during the first trimester of the heart. But these are the things again, 2/3, 1/3, and the total size is going to be 1/3. Look at this. This is the left axis deviation. This is a case of left axis deviation, and this is a case of common arterial trunk which we identified. Those who are G users, they will understand this value. My machine number was D210, 2010, 10th October, and this is an 8th of October. So this is almost 15-year-old video, and just see the 15-year-old video. I have put it half by half. You can see interventricular septum is good. Both chambers are filling. You can have again both vessels are crossing. Then you have got 1, 2, and 2 major outflow tracts which are fine, and it is formation of a V. 15-year-old clip I am showing you just for the sake of reference. I know that your machines are far better than 15-year-old technology today. So you should be able to identify all of them, and all of these things can be seen. 4-chamber view, interventricular septum crossing, tracheal V formation, and all. This is by HD flow. The moment you use a slow flow, you will have practically 4-chamber view, pulmonary artery bifurcation. Then again you have got a tracheal V formation. You go little up, you will see a thigh box and the normal subclavian arteries. So it's about you get that much of a details even at the 12 week or 13 week of the fetus. To begin with, to learn first trimester fetal echocardiography, start at 16 week. Start doing echocardiography at 16 week. Gradually you reduce the gestational age 16 to 14, and then to 12 and 13. That's how you will reach your destination, and that's what you should be aiming, and that's what you should be thinking of doing fetal echocardiography nowadays. Now a new machine, this is new expert 22 machine, but even in a grayscale you can identify, okay, that the things are normal. 4-chamber view, outflow tract which are fine, and 3 vessel forming a 3-vessel trachea view. So I'm practically not worried about those things. And for me, even including the arch can be easily visualized, and both the arches can be seen. Not only by that, the moment I use my slow flow, I think I'll be able to identify those things far better, including the vena caval view, bicaval view also, which is seen. This is a venous system, this is arch, this is pulmonary arch, 3-vessel trachea view formation. And if I use my volume image, then you will have both the arches just seen so beautifully that you never forget. The things are all good, brilliant. That's what it is easily doable, and the things are going to be visible. So this is one venous system. I'm just trying to tell you that the azygous arch which is visible, you can see both the arches. You have all volumes. Everything can be visible. All venous system. I'm trying to show you fetal venous system evaluation right in the first trimester of the pregnancy, and that's what your aim also should be, to look at the venous system. This is a hammock view we try to see in the first trimester, second trimester. This is a classic hammock view which is visible during that, a pulmonary artery bifurcation. You name the structure, we will be able to show you how these things are going to be visible. The moment you say volume image, it gives you much details. This is the diastole and systole. This is diastole, systole. I know that both chambers are feeling well, ventricular septum is good, vessels are crossing, the things are normal. I am very confident that I don't need to see these things even at 20 weeks, because I'm all happy about looking at those fetal heart right at 13 week of the gestation. Just look at the diastole, systole, and that's what I'm interested. trying to show you, let me annotate everything. Just this is the left ventricle, left atria, right ventricle, main pulmonary artery, ascending aorta. You have arch, brachiocephalic vein, and this is what during diastole, and this is during the systole. You can see everything right there in the first trimester. There is again 13-weeker heart, and I think you should be able to look whatever details you want, we can have those details which can be really visible during that first trimester of the heart. Let me show you some of those abnormal cases so that you can appreciate. Now we can see many things. What are the things which are abnormal? Here you can see that look at this. You have got single valve which is opening. This is a classic atrioventricular septal defect. It is not only atrioventricular septal defect, but look at the shape of the atria which are same. So this is left atrial isomerism, atrioventricular septal defect, and along with that, if you can see here one more case of the atrioventricular septal defect. There is a huge atrioventricular septal gap, and this is single valve which is visible. So this is a tetralogy of Fellow, which I'm just giving you the diagnosis, but you will find a very classical thing. 4-chamber normal. Just at the opening you can see the VSD. You have a small pulmonary artery, but look at a couple of things which are very distinctive feature of the tetralogy of Fellow. One is ventricular septal defect. This is here there is a large defect which is here at that point, and just at one clue, a narrow pulmonary artery, but one of the important clue is the formation of Y, not V. Usually pulmonary artery and aorta will form V. Here it is forming Y. It will end up in the middle of the arch, and that is what is required. It is here, and then this is a complete arch. So it is joining in the middle, and this is what you can see, that formation of a Y is a classical early sign of tetralogy of Fellow, and that's what you should be able to. This is one more case, and this is one more case of the overriding of the aorta. Eventually this is again ventricular septal defect, overriding aorta, infundibulary and the valvular pulmonary stenosis, and that's what you can identify. One more case of the tetralogy of Fellow which should be seen. One more case. Let me show it to you. Here it is a classic case of a reversal of flow at a 12-week. So look at this. Big aorta, very small pulmonary artery, but the color flow is different in pulmonary artery because there is a severe pulmonary stenosis. So blood to the lung doesn't go through pulmonary artery, it goes to the aorta, it comes back from ductus arteriosus to the lungs. This is PAVSD, pulmonary artery with stenosis with VSD. So that's what you can identify even at 12 weeks. Just going one more, right heterotaxy syndrome. I'm just showing it to you that you can also see the right heterotaxy, which you can always identify. Look at this. It appears quite normal, but look at this. It is only one opening at 4-chamber view, then it bifurcates into 2 ventricles, and then outflow tracts are crossing it normally. So this is what you should be able to, or pericardial effusion, severe right atrial enlargement. This is a case of tricuspid atresia. Tricuspid valve doesn't open and gives rise to the blood, and it is a classic tricuspid atresia which you should be able to identify. Look at this 4-chamber. This valve doesn't open. This is mitral valve dysplasia. Simple. If you add on the color, you will have a very with the clarity that this is not opening and this is not closing. So you have a thymic hyperplasia. It was a 22q11 deletion, a classical ectopia cordis with pathology of Kentral, which was there, and this was a case of, again, one more case of atrioventricular septal defect which was identified. Look at this. The pathology is like this. You have intraventricular septum which is good, 1 chamber well developed, but look at this region. You have to have one opening at a tricuspid valve, one as a mitral valve, and this should be the crux, complete normal intraventricular septum. But the entire system is one single opening, that those things you can identify. Severe arch hypoplasia, this was a case which was diagnosed right at 12 weeks. Look at very large pulmonary artery, and there is a reversal, and this is the arch of the aorta, which is very small, narrow arch hypoplasia, diagnosed at 12 weeks. Again, double aortic arch. This is one which was diagnosed as double aortic arch, which was very peculiar. You should be looking at the double aortic arch which was there. You can see the ring formation and these vascular ring formation. When you add on the volume, you will have these double ring vascular formation, and these things can be visible. So I can go on showing you. I can go and showing you the different causes of the fetal echocardiography, abnormal things about the fetal heart. But I would like to tell you one thing. It is much easier than you think. Okay, it is not difficult. It is the main point is to start doing, and start doing at 16 weeks. Then, as I told you, come down to the gestational age. That's what is going to be the crux. And I'm again repeating, it is much easier than you think. Use your machine appropriately, and you will be able to see everything right there. So we just recommend few things. Have absolute appropriate machine settings. That is the crux or the main point how you are going to identify first trimester fetal heart anomalies. Have a good settings of 2D, have a good settings of color, HD flow and a slow flow. Then you will be able to identify. Utilize grayscale and the color simultaneously. Use volume. That will guide you to understand the anatomy in general. Otherwise, what happens? Your mind is working. You start taking sections. In your mind, you try to collect all the sections and get a good complete picture. Here I am asking machine to do it. Okay, I make machine my slave. Okay, you do it for me. It's going to do it for you, and it's going to give you one complete picture. Okay, this is what the system is inside. So I ask my machine to do it for me. This is exactly what the volume imaging is. There is nothing very special about it, but use it. If you have got a volume probe, if you are not using it, then again, that's not the right correct situation. So I want you guys to start doing it, and that's how you should be doing it. Again, I'm putting it at one more time. It is easier than you think. The moment it goes in your mind, it is easier, then you start doing it. If I put it, it's difficult, try it. No. It is easier than you think, then you will try. The moment I say, no, it is difficult, try and see, there is going to be difficulty, you come across those difficulties. No way. It is easy, then you start doing it, then you find some difficulty, but eventually you overcome those difficulties. So that's what my aim is. Look at an NT and fetal echo, attempt to look everything. And that's what is going to give you a complete idea. And so volume is going to be the key in the first trimester screening. And whenever next time you do fetal echocardiography, I know this is not should be your situation. Thank you very much.